Our target therapy was Sonagib, and we focused on basal cell carcinoma, which is a skin cancer. Most subtypes of skin cancer are named after the cell that they have arisen from. Skin cancer is also normally classified as melanoma or non-melanoma because melanoma skin cancer is typically more aggressive. While there are three most common skin cancers, basal cell carcinoma, squamous cell carcinoma, and melanoma, there are many more rare subtypes of skin cancer that make up 1% of cases. Our skin makes up the largest organ of the human body. It's responsible for environmental protection from injuries, infections, and more. It's also responsible for helping regulate body temperature. Skin is made up of three different tissue layers: the epidermis, the dermis, and the subcutaneous tissue. Skin cancer can occur in each of these tissues, but most commonly is found in the epidermis. The epidermis is made up of 4 layers and contains many cells, including keratinocytes, the most common cell type of the epidermis. The next layer, the dermis, includes vascular tissue, muscles, nerves, mast cells, and more. The dermis layer provides structure through collagen proteins. Lastly, the dermis lies on the subcutaneous tissue. This layer is made up of lymphocytes, and its main role is injury protection. The outermost layer of the skin, the epidermis, is where most skin cancer occurs. Made up of 4 layers, the basal, the squamous, the granular, and the cornified cell layers. They are divided and named based on the morphology of their keratinocytes. Common epidermis keratinocytes include squamous cells and basal cells. Epidermis skin cancer is most commonly found in the basal cell layer. These cancers are referred to as basal cell carcinoma. Our target therapy, Sonagib, is used to treat basal cell carcinoma. Basal cell carcinoma is classified in 4 different groups: nodular, superficial, infiltrative, or micronodule, and morphiform. The basal cell layer gives rise to all other epidermis cell layers, so it makes sense that mutations that cause uncontrollable cell division occur most often in this layer. Basal cells are constantly proliferating to renew the outer layer of the epidermis. Mutations in genes that synthesize for patch1 and smooth-end proteins for the hedgehog signaling pathway are responsible for the majority of basal cell carcinoma cases. Sonagib targets smooth-end, a protein in the hedgehog signaling pathway, coded for by an oncogene. In normal adults, the oncogene is completely inactive, blocking the hedgehog pathway, while adults with skin cancer show expression of activation proteins that signal the pathway. Activation comes from specific hedgehog proteins referred to as ligands. The most studied ligand is the SONIC protein. However, there are 2 other ligands that activate the pathway, known as the Indian and the desert proteins. The SONIC protein is responsible for binding to the protein patch homolog receptor, referred to as PATCH1. The genes that synthesize PATCH1 receptor is known to be a tumor suppressor gene. SONIC proteins will bind to the receptor and activate the expression of smooth-end proteins. Downstream, smooth-end will signal the activation of GLI transcription factors. The transcription factors have DNA-binding zinc finger domains that target for specific genes and regulate transcription. Sonagib inhibits the signaling of GLI and factors by targeting the binding pocket of smooth-end. Sonagib is an oral capsule that works by inhibiting the hedgehog signaling pathway. The development of this therapy is important for cancer patients who are untreatable by surgery and radiotherapy. This is common for patients with metastatic tumors such as locally advanced basal cell carcinoma. Locally advanced basal cell carcinoma is classified by the invasion of tumors in surrounding muscles, bones, or cartilage tissue. Sonagib can stop cancer's hallmarks, evasion of growth inhibitory signals, and metastasis of cancer cells.
So now I just want to touch a little bit about the tumor suppressor gene that is most commonly mutated in basal cell carcinoma. So we'll be talking about PATCH1 receptor today, and this is a type of transmembrane receptor, which means it just is embedded within the plasma membrane of the cell. And first, I just want to start off with the normal function of this type of tumor suppressor gene. So normally when there are no hedgehog ligands present around patch 1 will be bound to the smoothing protein, therefore suppressing it. And what this will do is this will block the hedgehog pathway transduction so that it will not occur. Now, when there are hedgehog ligands present, what will happen is these hedgehog ligands will bind to patch 1, therefore allowing it to release SmoothN, and this uninhibits it as well. And now SmoothN will prevent to the tip of the primary cilium. And this is where all the GLI group of transcription factors are kept in interacting proteins. And one of those is known as suppressor fuse, and this is also abbreviated as SUFU. And once these transcription factors are activated, these factors will be sent to the nucleus where the genes are kept for self-renewal, survival, angiogenesis, and cell fate. And you're probably wondering, how does this turn itself off? Well, the GLI transcription factors provide a feedback loop, and this goes back to the patch 1 receptor, and it allows it for it to auto-regulate itself. So therefore, it can inhibit the pathway and cut it off whenever it needs to. Now I want to talk to you about what happens whenever there is a mutation in patch 1. So we know it's a tumor suppressor gene, so that means it loses its function. And when it loses its function, this means that there's no need for the hedgehog ligands to be present in order for the hedgehog pathway to become activated. They're not necessary anymore, because what's going to happen is patch is no longer there suppressing SmoothN. It's going to remain activated, and the pathway will no longer be suppressed. And what this means is that the cancer cells now have this unstoppable pathway, because they can proliferate with ease because they're having access to all of those genes that were responsible for so many different things like cell fate and angiogenesis. And the reason why they do have this unstoppable pathway is because the feedback loop that patch 1 is supposed to be in charge of is no longer working because it's lost its function. And by doing all of these things, the cancer cells have now achieved the hallmark of enabling replicative immortality. And this is just a quick image about everything I just explained to you. You can just see there's a patch 1 receptor normally. There it is with the presence of the HH ligands or the hedgehog ligands. And you can also see kind of what happens whenever patch 1 is mutated and no longer works.
All right, so we're on to the epidemiology of basal cell carcinoma, and we're going to start with the incidence. So over 4 million Americans are diagnosed with this every single year, and 1/3 of newly diagnosed cancers worldwide are said to be skin cancers, according to the Skin Cancer Foundation. Many of those skin cancers are basal cell carcinomas. It's the most common type, and it's considered the most common malignancy afflicting humans, meaning the presence of a malignant tumor. And the figure is just a comparison of some of the skin cancers. So diagnosis of non-melanoma skin cancers increased by 77% between 1994 and 2004 in America. And the incidence is specifically increasing worldwide by about 10% yearly. And the most common locations for basal cell carcinoma are on the face and neck, which later I'll get to UV rays were the biggest risk factor for basal cell carcinomas, and it will make sense then. But the last thing is they're likely underreported to cancer registries due to the associated cost and the large amount of tumors present with basal cell carcinomas. The takeaway from this is that basal cell carcinoma risk is extremely high. They're an incredibly common cancer. Though they're incredibly common, fortunately, the mortality associated with basal cell carcinomas is extremely low. 2013 Dutch study found a mortality rate of 0.08 per 100,000, that says person years. And so given that it was taken over 1 year, you can basically say that for that year it was 0.08 per 100,000 people, and that is an average over for a given year over this time period of the study. But that incidence is certainly low, but when the context of human lives, it's non-negligible. And we talked about different kinds of skin cancers. It's actually the squamous cell variety on mucosal surfaces that accounted for the greatest amount of deaths in that mortality study. It's been labeled a disease of the elderly, BCC has, and when we cover demographics, we'll look at why, but there's multiple studies that have referred to it as some iteration of the disease of the elderly. So now on to variation among demographics. So before I get onto this, I just want to say like why that basal cell carcinoma's death rate is low, and that's because of its slow cell growth rate and its inability to readily invade other tissues most of the time. It does not metastasize easily. And when we look at the variation among demographics, it's pretty simple. The correlation between pale people and incidence of basal cell carcinoma. It's if you burn more easily, you're going to contract basal cell carcinoma more easily. And so it also varies heavily depending on geography. Equatorial areas with very little shade are going to have more UV exposure, as I'll get to, and particularly populations of fairer skinned people in those areas are going to be introduced to more UV, and they're going to have higher incidence rates there. Australia, Northern Australia, is a particularly good example, very high incidence rate. And that is because of factors I listed. And so also age, individuals over age 50 are also a high-risk group. And that's simply because they've had more time to be exposed to cumulative UV. They've had more DNA damage, more DNA repair, and more mutations associated with that repair. And a longer time to accumulate mutations means that basal cell carcinoma is more likely. And with the exposure, the face and neck, body parts that aren't readily covered by clothes, it makes sense why they are very common on the face and neck. So this is just a study looking at light exposure, UV light exposure as a risk factor. It's a 2014 cohort study that evaluated a number of risk factors, including UV light, and their correlation to do different skin cancers. Basal cell carcinoma was one of them. And this was a large study. It followed over 100,000 American women through an observational study. And they basically followed these women who weren't diagnosed originally, and they looked at what amount of UV they were being exposed to, divided them into quintiles, quintile 1 being the lowest exposure, quintile 5 being the highest exposure, and then they looked at the rates of basal cell carcinoma among the quintiles. And the main thing I want to point out here is that the p-values, and I also added a confidence interval for the second one just to add some variety, they're highly significant. Look at the p-value, 0.0001. That is statistically significant. And I don't see one in that 95% confidence interval. So it's highly correlative between sun exposure early in life, 15 and 20, late adolescence, and late in life. So, and these, I have RR on there. That's a relative risk, and it's comparing not exposure to non-exposure, because that would be impossible with UV exposure, considering everyone is exposed to a little amount of UV in their life at least. And it's comparing the highest exposure quintile to the lowest. Quintile 5 over quintile 1 is the relative risk, quintile 1 being 1. So that's how the confidence interval and the p-value were acquired, and it's highly significant. Wrapping this up, this is just a more clean lineup of the data. Age adjusted, obviously it has to be age adjusted in order, because age is a very strong correlative factor to the contraction of basal cell carcinomas, and skin color is too, so they had to do multivariate adjusted as well. But again, I'll reiterate, the p-value for the trend is highly significant. And if anything can be taken away from the study, it's the importance of sunscreen. Sunscreen is going to protect from those UV rays, especially if you're a fair-skinned individual, and those UV rays look to be highly correlative.
All right, so Sonagib, our drug, was approved by the FDA in 2015 based off of a double-blind phase 2 randomized control study. And they had 2 different doses of Sonagib, and they compared them. It was the 200 milligram and 800 milligram. And there were 230 patients that either had locally advanced basal cell carcinoma or metastatic basal cell carcinoma. And these people were also not eligible for surgery or radiation. And the drug was said to have a clinical benefit if it had an objective response in at least 30% of patients. And so in the end, the 200 milligram group was found to be the most effective dose for patients with advanced basal cell carcinoma. So we're just going to focus on those results today. So here I just want to show you the efficacy of Sonagib 200 milligrams on the locally advanced patients. These are the results right here for the objective rates. And this does include complete response and partial response. And we see a nice increase here from the primary analysis, which was at 6 months, to the 18-month analysis. So we see an increase here in objective response rate. And then we also see a high objective response rate here at the 30-month analysis. And they just had divided the patients up among histology here. And we do see similar trends with the locally advanced patients taking the 800 milligram dose. And then as far as the efficacy of the 200 milligram dose on metastatic patients, it didn't really change from the primary analysis, and its objective response didn't reach 30%, unfortunately. So while taking Sonagib, people mainly experience these symptoms right here. So muscle spasms, alopecia, dysgeusia, nausea, and blood creatine kinase increases. And it was seen that less adverse events happened here in the 200 milligram group versus the 800 milligram group I have circled in red here. And then serious adverse events, which are the grade 3 and grade 4 events, they were seen more in the 800 milligram group. And the most reported serious adverse event was the raised creatine kinase concentration. You can see that here circled in blue. And then also fewer adverse events leading to dose interruptions or treatment discontinuation occurred in the 200 milligram group. So if we look at a risk-benefit analysis here between the two doses, we can see that the 200 milligram is a more favorable dose because it had manageable adverse events and a low discontinuation rate. And then, so here we're going to look at the median durations of progression-free survival. So locally advanced patients had a progression-free survival of about 22 months here in red, versus the metastatic patients who had about a 13-month progression-free survival here in orange. So we do see that locally advanced patients had a better progression-free survival here on our drug. And then overall survival, as of this graph, the median survival isn't met yet, which we would see right here at the 50% mark. And so we do see the locally advanced patients had a better overall survival versus the metastatic patients. And in an article I found, it mentioned that metastatic patients, in them, the overall survival has significantly increased since the 1990s. And that's probably due to improvement in drug therapy. But that just shows that we've come a long way in that realm. And then the first SMO antagonist on the market was vismodegib, and it's still on the market, and it is approved for locally advanced and metastatic basal cell carcinoma. So you may be wondering, why would we add Sonagib to the market? So these two drugs do have many similarities as far as their patterns of adverse events, efficacy, and tolerability profiles, but they do differ in pharmacokinetics as far as in volume of distribution and half-life, which could make Sonagib a more useful drug. And this right here is just a comparison of the two drugs here that I have found. And so, let's see here. All right. And so the clinical subtype for our drug is, it's going to be dependent on the transmembrane protein smoothened, SMO, that we've talked about throughout this presentation. And as far as propensity for spread, basal cell carcinoma is typically diagnosed before it spreads to other parts of the body. So it's a very survivable tumor. And you can see here in this graph that only a small percentage here in red and blue are diagnosed with advanced basal cell carcinoma. So metastasis is rare. And then for prognosis, whenever radiation and chemotherapy were the only options, locally advanced patients only lived around 7.2 years, and metastatic patients only lived around 2 years. And when we look at the estimated 2-year overall survival when taking Sonagib, we see locally advanced patients have a 90% survival rate versus metastatic patients who have a 69% survival rate. And overall, I have read that metastatic basal cell carcinoma still has a poor prognosis, just like any other cancer that is metastasized. But when we look at non-spreading basal cell carcinoma, it is rarely associated with a fatal outcome. And then as far as risk of reoccurrence, that depends on the location of the tumor and the clinical/histopathological features. And then as far as treatment protocol, Sonagib is an oral capsule that's taken daily. And for patient experience, adverse events requiring dose interruption, they were reported in 43% of patients, and adverse events leading to discontinuation of the drug were reported in 30% of the patients. And so these are said to be manageable side effects. And I also thought it was interesting that in a phase 1 trial I found, Asian patients showed that they had a lower maximized tolerated dose of our drug. And then resistance is very common. There can be a mutation in the drug binding pocket that prevents Sonagib from binding. And this picture over here is just going to show the drug binding pocket, and it's 3 amino acids here in green. And other mutations can cause conformational changes in the SMO, blocking the drug from accessing the binding site. And with a large portion of people developing resistance, tumor response needs to be evaluated regularly. Additionally, if you were previously on a different hedgehog inhibitor, you will probably be resistant to Sonagib.
I just want to give you a little bit about the basic background of science on how Sonagib actually works within your body. So just a little bit of information. It's also on the market known as Odomzo. And like Kelly said earlier, it's usually given to patients in pill form. And this is usually given to patients when surgery or radiation is no longer an option. And this can be because it's on a certain area of the body where it's close to a vital organ, and this is just not the best case scenario for this patient. And now, just moving on to like the target and exactly how it works. So if you remember back earlier, we said that really the cause of this cancer is this PATCH1 transmembrane receptor, that mutation, that loss of function, this tumor suppressor gene. So you kind of have to figure out, how do we target something that's no longer there, no longer has a function? And the answer to that is you need to go back up the pathway and find what it used to bind to and what it used to inhibit. So Sonagib is actually an antagonist, and what this means is it works by blocking something else from being able to bind to another protein. And it is an antagonist for the Smoothian protein that we talked about earlier. And what it does is it fits into Smoothian's binding pocket and interacts with the 3 amino acids, arginine 473, arginine 400, and glutamic acid 518. And what it does is by fitting into Smoothian's binding pocket, it will inhibit it from activating the downstream pathway. And how it does this is because since Smoothian is inhibited by this type of drug, it can no longer bind to those GLI transcription factors we talked about earlier in the presentation. So this drug is also highly specific to its intended target, and so far there have been no off-target effects specified. They have conducted several different rounds of screening for channels, receptors, kinases, transporters, and proteases, and so far no activity has been identified for these examples. And just to touch a little bit more on the pharmacokinetics, so this drug does show very minimal potential to affect the metabolism of other medications within the body. And how they test for this is they look at whether or not it inhibits the cytochrome P450 enzyme. And this is just an enzyme within the body that's very important for clearing compounds during or metabolic processes. And whenever they screened for this or looked for this, it came back that they did not inhibit this type of enzyme, therefore meaning that you can take other drugs while taking this drug. And we know that cancer patients usually have to take more than one drug while they're getting different treatments. And now just lastly, we want to talk about the therapeutic index and the dosage. So the dosage that was required to produce a therapeutic effect for patients was 200 milligrams, and the dosage that was required for toxic effects to be seen within patients was 800 milligrams. And those that were assigned to the 800 milligrams group, they were seen to have grade 4 and 3 toxicities, which we know can really inhibit your lifestyle and also can cause you to be hospitalized. So most time when you have these, they will discontinue treatment very quickly. And some of the ones that grade 4, 3, and 4 toxicities they saw was anemia, fatigue, neutropenia, CK elevation, and nausea. And neutropenia is that's just where there's an abnormally low amount of white blood cells within the blood, and also CK elevation is just CK just stands for the creatine kinase protein that's in your blood. So obviously the blood's being affected, and as you can relate back to class, we know it's like the quickest way to get taken off of a treatment. And lastly, the recommended dosage for this drug is 200 milligrams twice a day.
And before we go to our references, I just want to jump back. Where is it? Right here. Just as far as the cost with these two drugs, Sonagib is cheaper. You can see the prices right here. And also there are reimbursement options as a part of the Sonagib program. And then here are our references.